Let's jump right in. We're going to explore a really fascinating reality of modern orthopedics in this explainer. Because treating a broken wrist, well, it's not just about fixing a bone. It's really about restoring a patient's entire livelihood. When we talk about distal radius fractures, which happen at the end of the forearm, right near the wrist, we aren't just dealing with skeletal mechanics. No, we're dealing with a person's ability to feed themselves, perform their job, and frankly, maintain their identity. So welcome to a deep dive into what we call the surgeon's dilemma. This dilemma actually frames our entire medical decision-making process. Think about it. The patient's daily life is just as critical as the X-ray itself. The treatment for a low-demand patient, maybe someone who's retired and leads a quiet, fairly sedentary lifestyle, is going to be fundamentally different from that of a high-demand professional. We're talking about an elite athlete, a concert pianist, or, hey, even a fellow surgeon. Even if the X-ray shows the exact same fracture pattern in both patients, the treatment pathway completely diverges. For the retired individual, a cast and a few months of conservative healing might be perfectly fine. But for the professional whose whole career depends on exact, pain-free micromovements, we are looking at immediate, hyper-precise surgical intervention.
And just to wrap your head around the sheer scale of this issue, hand and wrist injuries account for a staggering 25% of all sports injuries. That is a massive chunk. It makes the wrist an incredibly common battlefield for orthopedic surgeons. From athletes falling on an outstretched hand to these high-energy collisions out on the field, a literal quarter of the trauma we see in sports medicine happens right here in this incredibly complex, delicate joint.
So, to get specific, a distal radius fracture is a break in the larger of the two forearm bones exactly where it meets the wrist. You know, the human hand has this incredible evolutionary design built for profound precision and really complex motion. From typing on a keyboard to performing a delicate surgery, preserving this intricate anatomy is absolutely crucial to maintaining a patient's quality of life. If you lose the perfect alignment of that radius bone, you essentially lose the fine motor control of your fingers. It's all connected.
The historical weight of these injuries is also pretty massive. Honestly, there is perhaps no other fracture in all of orthopedic literature that has garnered so many eponyms, names based on the doctors who first discovered them. We've got Colles fractures, Smith's fractures, Barton's fractures. And this incredible variety exists because the distal radius can break in a whole multitude of ways. It all depends on the angle of impact, the sheer energy of the fall, and of course the patient's bone density.
Now things get even more complicated when we talk about intra-articular breaks. That basically means the fracture line crosses directly into the joint space itself. Take a chauffeur's fracture, for example. It was historically named because it often happened when early automobile drivers experienced violent backfiring from their starting cranks. It involves a very specific break of the radial styloid. Or consider a die punch fracture. This is an intense depression of the lunate fossa. It's literally like a hole has been punched right into the joint surface. Both of these injuries completely disrupt that perfectly smooth gliding surface of the wrist.
So when a surgeon actually goes in to fix this, they aren't just piecing together a broken plate. They are engaging in highly precise architectural reconstruction. Surgeons absolutely must restore three crucial biomechanical angles: the palmar tilt, the radial height, and the radial inclination. As the old medical saying goes, motion is life. If these angles are off even slightly, the wrist simply will not bend properly. You won't be able to achieve the full flexion needed to tightly grip a steering wheel or the extension required to push yourself up out of a chair.
Which brings us to a core medical philosophy here. The ultimate success of a treatment isn't defined by having a pretty, picture-perfect X-ray. Actually, scratch that. It is strictly defined by whether the patient can return to their specific daily job and vocational demands entirely pain-free and without the looming risk of future degenerative arthritis. Notice the heavy emphasis on vocational activities. The goal isn't just to make the bone look structurally sound, it is to hand the patient back their life and their career. To achieve that kind of functional return, we always follow a sequential set of goals. We preserve the function, we realign the normal bony anatomy, and we promote bone healing. But the kicker is really allowing for early finger and elbow range of motion. We heavily emphasize early movement to prevent the hand from freezing up. Let me tell you, stiffness is the ultimate enemy of the hand. Prolonged immobilization can lead to really debilitating complications like chronic regional pain syndrome. That's a severe condition where the nervous system completely overreacts, causing intense pain and stiffness long after the actual bone is healed up.
This is where the really high-stakes calculation happens. We have to carefully weigh the energy of the injury against the specific physical demands of the patient to choose between a conservative cast and a surgical scalpel. For a low-demand patient with a low-energy fracture that hasn't displaced very much, close treatment, like a traditional cast, is absolutely perfect.
But if we're dealing with a high-energy injury, a severely shattered bone, or a patient whose career demands absolute anatomical perfection, we immediately shift gears to surgical treatment. The patient's occupation and their activity level are the absolute ultimate tiebreakers in this decision process. Furthermore, if a patient is highly active, we simply cannot tolerate poor anatomy. There is zero wiggle room. We actually have strict mathematical triggers for surgery. We immediately operate if we see unacceptably skewed angles on the X-ray. We're talking about a radial inclination of less than 15 degrees, a dorsal tilt greater than 10 degrees, or an articular step-off that's wider than 2 millimeters. Think of that 2 millimeter gap kind of like a pothole in a fast-moving road. If a high-demand patient, like an athlete, constantly grinds their wrist over that tiny 2 millimeter pothole, they're going to rapidly develop crippling arthritis. It's practically guaranteed.
When those numbers do trigger a surgery, well, we have a complete arsenal of options at our disposal. It's a true hierarchy of interventions ranging from your basic casting to external fixation, which is where pins are placed outside the skin to hold the bone in traction, all the way up to highly specific internal plates that are completely customized to fit the patient's unique fracture pattern.
For those really complex breaks, especially in our high-demand professionals, internal fixation is the route we almost always take. Using precise metal plating on the volar, which is the palm side, or the dorsal, the back side of the wrist, provides incredible rigid stability. We can even use fracture-specific focal plating for those tiny, really stubborn bone fragments. This rigid internal scaffolding is a total game changer. It's what allows for aggressive early rehabilitation. Because the plate is holding that bone tightly together, the patient can actually start moving their fingers and wrist almost immediately.
And this brings us to open, reduction, and internal fixation, commonly known in the field as ORIF. This is the absolute gold standard for active patients with good bone quality. For these folks, we absolutely must restore the joint surface perfectly to match their high occupational demands. We cannot just rely on blind manipulation or pulling the wrist in a cast and hoping for the best. No, we have to open the wrist, visualize the joint surface directly, and fix it perfectly with plates and screws. This is the exact pathway that reliably gets a professional athlete back on the field or a manual laborer back to work.
Now, you might be wondering about less invasive options. There's percutaneous pinning, which is a technique where we use smooth metal wires called K-wires, driven directly through the skin to hold the bone fragments together. It's minimally invasive, and it's great for certain types of fractures. However, it's often just not robust enough for the intense, immediate load-bearing required by a professional. If you have severe comminution, where the bone is basically shattered into many tiny pieces, or if the patient needs an incredibly early return to high-demand activities, pinning is totally contraindicated. The wires just don't provide the same rigid lock as a solid titanium plate.
Which leads us to a really fascinating philosophical challenge. When we look at modern sports medicine, professional athletes are often treated as highly valuable commodities. The whole concept here is the commodification of the body. Their bodies are quite literally businesses that generate massive revenue and entertainment. And, well, businesses must remain open. When an elite athlete breaks their wrist, the treatment decision isn't purely a medical one anymore. It morphs into a high-stakes business negotiation.
It's vital to understand the intense environment orthopedic surgeons operate in here. We face massive external pressures from coaches, management, and heavy financial stakes. The coach wants the player back for the championship game next week, but the surgeon knows the bone biologically needs 6 weeks to fully heal. If they're rushed back, the athlete risks the dreaded coach's finger, a permanent stiffness and pain that ultimately ruins their performance down the road anyway. The goals of the medical team, which are focused on long-term health, directly and intensely clash with the sports franchise, which is focused on immediate victory and revenue.
So, as we wrap up this explainer, we are ultimately left with a profound ethical question about modern medicine. When evaluating the occupation of our patients, especially in these ultra-high-stakes environments, we have to ask ourselves, when treating a fracture in a professional athlete, are we simply healing a patient, or are we tasked with repairing a million-dollar industry? It completely shifts how we view a simple broken wrist, doesn't it? Thank you so much for joining me on this deep dive, and I really hope this changes how you look at the intersection of human anatomy and our daily livelihoods.